Good morning, and welcome to this webinar on nomenclature. We at VieSID welcome you to go through this seminar in order to understand better the nomenclature that will be used in future webinars. At VieSID, we do recognize that our worldwide presence creates some challenges with terminology. Different countries have different nomenclature, and we're pleased to provide you with this introductory session to review some of the most common terms and concepts to assist your understanding in future webinars. Professor Slavicek recognized that we as living beings are constantly adapting to our environment. And as you progress through the various webinars, you'll see that our challenge as dental professionals is to assist our patients navigating these challenges, their masticatory organ, so that they can maintain optimal health. We'll first look at some introductory terminology. We'll study life, stomatic gnathic system, masticatory organ, allostasis, homeostasis, and adaptation. Professor Slavicek named his first book, The Masticatory Organ, and he mentions in the foreword that the term leaves out many of the important functions of the system. For the purposes of this lecture, we'll use the term masticatory organ as synonymous with stomatic gnathic system, which is a more encompassing term discussing the variety of functions of the system. Three very important principles are critical to understanding how an organism will react to its surrounding environment. The first is allostasis. This is the process by which the body responds to stressors in order to regain homeostasis. But what is homeostasis? It's the tendency towards a relatively stable equilibrium between interdependent elements, especially as maintained by physiological processes. Stability is the key. Finally, adaptation is a change or the process of change by which an organism or species becomes better suited to its environment. In our diagnosis, case planning, and treatment, it's critical to have these three principles in mind. To carry on with our introductory topics, we'll look at cybernetics, feedback control systems, anamnesis, phylogenesis, and ontogenesis. In 1948, Norbert Wiener wrote his book Cybernetics. This very important work linked control and communication in the animal or machine between various sciences. In dentistry, we recognize that we are dealing with a complex biologic system with many external influences and internal interrelationships. Now, the definition of cybernetics is the science of communication and automatic control systems in both machines and living things. The concept of a feedback control system is important in the masticatory organ as it introduces negative and positive feedback systems, which we will see influencing our diagnosis and treatment in our dysfunctional patients. In the cybernetic model, what does a feedback control system look like? As you can see by this diagram, the environment encompasses the organism, which in turn influences the masticatory organ. Now, similarly, the masticatory organ has three main categories that interrelate. These are structures, function, and the soma-CNS psyche triad. Understanding this model can shed light on the complex system that we face as professionals every day. Within this cybernetic model of the masticatory organ, we're especially concerned with three structural units on the left side of the diagram. These are the occlusion, the neuromuscular system, and the cranio-mandibular system, which we'll define shortly. Foremost in the VieSID system of diagnostics is the need for listening to our patients. This is a process called anamnesis. It's the patient's recounting of their own past history in their own words, which initiates our investigation. Now, listening is the key, and often our patients will give us a very good overview of what our examination is about to find. These two definitions relate to discussions about evolution and growth and development. Phylogenesis is the evolutionary development and diversification of a species or group of organisms, or it's a particular feature of an organism. Ontogenesis is the development of an individual organism or anatomical or behavioral feature from the earliest stage to maturity. Some basic concepts next. First, we'll define tooth movements, condylar movements, and then we'll look at the neuromuscular system and the CMS. Let's look at the nomenclature of mandibular and tooth movements that often are confusing due to the various terminology used in different countries. Here's the list of the terms we'll define. Mediotrusion at the level of the condyle. Mediotrusive and laterotrusive at the level of the teeth. Protrusion and its reciprocal retrusion, lateral protrusion, and we'll study various synonyms for each. We see in this graphic the mandible, and it's going to make a movement to the patient's left. This is a movement of the right condyle towards the midline and is defined as right mediotrusion or mediotrusion right. If the mandible went to the patient's right, the left condyle would be deemed to be a left mediotrusion or mediotrusion left. At the level of the teeth, tooth 4-6 in our example is said to be moving mediotrusively. Again, this is towards the midline. 3-6, on the other hand, is moving laterotrusively or away from the midline. The synonyms to these movements would term the moving condyle, in this case the right condyle, as the orbiting condyle, and the left condyle would be the rotating condyle. Now the balancing side equals the mediotrusive side. They're synonyms. And tooth 4-6 is said to be on the balancing side. The 3-6 is on the laterotrusive side, which is also again called the working side. Contacts on the balancing side are balancing contacts, otherwise termed mediotrusive contacts. And on the working side, teeth contacting would be working side contacts. Again, the balancing side equals the mediotrusive side, and the working side equals the laterotrusive side. Let's see a laterotrusive or working side movement in the second and third quadrants. This graphic looks from the anterior at the second and third quadrants, and we'll make a movement of the mandible once again to the patient's left. Note that as the teeth move left, the guiding cusps are steeper as the teeth are more anterior. For example, the 5 excludes the 6, and similarly the 4 will ideally disarticulate the 5 and 6 in excursions. And finally, the 3s will take over as the dominant tooth in lateral guidance. Remember this as we study the concept of sequential guidance in a few minutes. Function of the teeth can be divided into 2 main paths: an incursive motion, which is, for example, in swallowing, speaking, and mastication. And these are primarily vertical motions. And excursively, primarily in bruxing motions, which are mainly horizontal. Again, in our review of just how the lower and upper 6 relate to each other, let's study an excursive movement of the mandible to the left. This would be left lateral protrusion. Now, how do the teeth move against each other? The lower distal buccal cusp and the upper palatal cusp of the 6s trace a straight line through the mid-lingual of the lower and mid-buccal of the upper cusps. Careful consideration of how intricate the anatomy is designed reveals how to recreate ideal form without inducing pathology in our patients. Now, how about the mediotrusive movement of our 6-year molar? As the mandible moves to the patient's right, the arc created by the mediotrusive or orbiting condyle on the left will create a pathway just mesial to the mesiopalatal cusp of the upper 6 and through the gap between the distal buccal and distal cusps of the lower 6. In simple words, a peak must travel through a valley so as not to disturb function. 2 further motions need to be considered. Protrusion of the mandible, as it moves symmetrically forward, creates pathways which are straight mesial on the upper and straight distal on the lower. The final pathway to consider is lateral protrusive. This is moving the mandible laterally and protrusively at the same time. The intricate design of the occlusal is there for a reason. You have to ask yourself, what can happen if we violate it with our dentistry, or there is a change in arch form combined with the inevitable wear of teeth, creating interferences? Always remember to relate these pathways to the teeth. From basic tooth movements now, we'll move on to define the neuromuscular system, the NMS. The neuromuscular system includes muscles and their innervations, and the function of the NMS is to move the other structures of the masticatory organ. The neuromuscular system controls chewing and swallowing, breathing, head posture, speaking and communication, nonverbal communication, which of course is our appearance, the avoidance of interferences in function, clenching, and bruxing. Our final part of the cybernetic model to define is the first structural unit, the cranio-mandibular system, or CMS. It refers to the structural unit that connects the mandible to the cranial base. It includes the bony structures of the jaw and the extended and passive centering and protective ligaments with the active centering musculature. Now let's look in more detail at the components of the cranio-mandibular system. The basic osseous structures include the condylar process, the articular eminence, the temporomandibular joint region, middle ear, and the temporal bone. The ligamentary suspension of the mandible and the hyoid bone includes the sphenomandibular ligament, stylomandibular ligament, the stylohyoid ligament, and the temporomandibular joint, of course, has the joint capsule with the capsular and temporomandibular ligaments, the articular disc, and the retrodiscal tissues. Finally, the cranio-mandibular system muscles include the superior head of the lateral pterygoid, the deep head of the masseter muscle, and in 30% of the cases, the frontal head of the temporalis muscle. Professor Slavicek has always emphasized that the cranio-mandibular system must be studied dynamically in movement, and that the static relationships are really of secondary importance. Next, we'll look at definitions of the axis orbital plane, Frankfurt plane, review again eccentric versus incentric movements, the SCI, the TCI, the cusp inclination, hinge axis, therapeutic position, and the definition of a VTO. Reference planes are important as they allow us to compare and relate our findings, both on an ongoing basis to our patients, as well as between patients based on statistical norms. The Frankfurt plane is a line drawn through the inferior border of the orbit, i.e. orbitale, and the top of the external auditory meatus. The axis orbital plane is a line drawn from the hinge axis of the mandible, which is the center of pure rotation, and the orbitale point. The axis orbital plane in 2 dimensions is on average 7 degrees lower than the Frankfurt plane. In this diagram, the eccentric movement of the mandible is in-out, which is shown by the red arrow. The green loop depicts an incentric movement. Now, eccentric movements are more horizontal in nature and occur primarily in bruxism, whereas incentric movements are more vertical and occur primarily in function. Next, let's look at the occlusal plane angle. The occlusal plane is defined as a line from the distal buccal cusp of the sixth and the mandibular incisor. The basic occlusal plane inclination is calculated by extending this line up to the axis orbital plane. The sagittal condylar inclination is measured as the angle the condyle moves in a forward translation relative to the axis orbital plane. It's the same term as horizontal condylar inclination occurring in the horizontal or sagittal plane. The transverse condylar inclination is also called the Bennett movement, and it's measured as the angle the condyle moves to the opposite or contralateral side in a medial-obtrusive movement. This is relative to the straight anterior reference line. In this diagram, it's the red arrow with the angle being depicted in blue. Cusp inclination is the angle the cusp makes to the occlusal plane. This is if the tooth was sectioned through the central groove. Hinge axis is a geometric definition which is applicable to any rotating body in space. It's always present in a rotational body, and if there's pathology, the hinge axis in the temporomandibular joint can move away from the joint and be difficult to reproduce. If the joint's healthy, it's typically related to the condyle and is reproducible. Therapeutic position is a treatment position that does not correspond to the initial presenting position. This position, if desired, is determined through careful review of our diagnostic findings. The Gamma Dental software allows us to visualize the presenting condition and do a virtual VTO, which is a visual treatment objective. These can be applied to a variety of presenting factors to calculate the changes that are needed to improve the patient's physiology and function. Our next categories include skeletal class versus dental class, the concepts of occlusion, sequential guidance, functional geometry, the disocclusion angle, anterior guidance, and skeletal relations. We're all aware that our patients present with a variety of skeletal classes. It's important to understand that this is different than the dental class, which we see when the teeth come together. The maxilla and mandible can relate to each other in a variety of ways, which are summarized into class 1, a neutral relationship, class 2, a distal relationship, and class 3, a mesial relation. Note that, and this is an example, a class 2 skeletal type can be created by a large maxilla with an average mandible, or perhaps by an average maxilla and a small mandible. Many combinations exist, leading to a similar clinical appearance. Now, what's the distribution of the skeletal classes? Note that the class 1 skeletal type is not the majority in a European population. Professor Slavicek studied nature and what occurs naturally. From this evidence, he developed the concept of sequential guidance. The basic rules recognize that occlusion must be adapted to an individual's situation, and the natural compensatory mechanisms can allow a dysgnathia, which is a collective anomaly of the system, to function normally if they're not too extreme, and very importantly, if they slowly develop. Sequential guidance concept actually comes from nature and recognizes the intricate design of teeth with sequentially steeper disoccluding cusps. Understanding this concept allows us to provide optimal function and minimize negative influences on the masticatory organ. So to summarize, sequential guidance is an artificial concept that mimics nature. It's applicable to all skeletal types and adapts to compensated malocclusion. The goal of sequential guidance is to artificially produce an occlusion which will function as nature intended while assisting in orthodontics and restorative success. Pulling these factors together allows us to define the functional geometry of the patient. Now, this term recognizes there's an ideal combination of factors that maximize functional efficiency and minimize negative effects. In the VieSID basic curriculum, we explore this at length. The important factors, though, are seen on this diagram. To understand the functional geometry, we initially draw the axis orbital plane. Next, we determine the sagittal condylar inclination using Kondylography. We determine the occlusal plane inclination and come up with a relative condylar inclination. This is simply the sagittal condylar inclination minus the occlusal plane inclination. And basically, it reflects the relative angle the tooth travels as the mandible moves anteriorly. A steeper cusp would be more inclined to create an interference with the opposing tooth, while a shallow cusp would have less likelihood of doing so. But in our occlusal design, we don't want to make the cusp too short, as we'll lose chewing efficiency. Understanding functional geometry lets us calculate the ideal occlusal design. Now, knowing our parameters, we can now calculate a disclusion angle. This is the minimum clearance of the upper and lower teeth under load. We strive for 5 to 8 degrees. If it's too low, we'll have an interference. If it's too high, we'll lose efficiency. So here the formula defines the disclusion angle. The sagittal condylar inclination minus the occlusal plane inclination gives us our relative condylar inclination. We then subtract our cusp inclination, and this gives us our disclusion angle. One can see that a low SCI and a steep occlusal plane with steep cusps is a recipe for disaster. Now, what about our anteriors? First, it's very important to note the term intracoronal space. The photo at the top right is a perfect example of a lack of intracoronal space. The teeth are very tight. The upper left diagram shows the intracoronal space with some freedom for movement, and we strive to have an adequate amount of room in our cases. Finally, the lower diagram shows 2 critical points when we study anterior guidance. F1, which is called function point 1, is the point of contact of the lower incisor with the upper incisor in initial closure from its most retral location. As the mandible translates forward, it gets to function point 2, F2. This is at the most anterior movement with the anterior teeth touching, F1 to F2. We can now define the anterior guidance as the chord drawn between F1 and F2. We term this S. Now we can extend this line to the axis orbital plane, creating the anterior guidance angle. If it's too steep, it can create pathology. But when it's just right, it can reduce friction and maximize function. The individual skeletal pattern is the result of genetic programming and the interaction with environment and function. The very nature of how the masticatory organ is structured with rotational and translational elements makes the movement patterns in anatomy spherical in nature. Here we look at some important terms. The axis orbital plane is drawn in green. The occlusal plane again, which is the tip of the lower incisor to the distal buccal cusp of the lower six. The distance to the plane of occlusion, which is the axis orbital plane to the occlusal plane. The curve of Spee, which is seen here in red, is necessitated by the rotational nature of the function and is a line drawn from the occlusal plane to the rotational center of the mandible. Similarly, the curve of Wilson in the frontal plane is the curve dictated by the anatomy and function. In our next section, we'll take a look at Bruch's checkers, occlusograms. We'll define reference position, retrocontact position, and ICP. Here are two quick definitions of tools we use in VieSID Diagnostics, so you will understand what they are. The first are Bruch's checkers. These 0.1 millimeter very thin foils with red ink on them are worn to study bruxing, as well as daytime habits. Occlusograms, which are thin pieces of wax, allow us to study how the teeth come together in various mandibular movements chairside, and they're an integral part of our initial diagnosis. This one depicts protrusion. Note the heavy load on the central incisors and a possible interference in the 4-6 area. In all diagnostics in dentistry, it's critical to understand function at the level of the temporomandibular joints, irrespective of the teeth. In another webinar, I'll deal with this topic specifically. However, we'll define a few of the terms here. It's critical to have a condylar location defined as part of our diagnosis. And we define this as our reference position. But what is this? Number one, it's a stable starting point for a diagnosis. Number two, we know that our functional movements begin and end from close to reference position. Number three, our diagnosis must include an understanding of temporomandibular joint health. And for this, we need to have a repeatable starting point to diagnose from. So what's the difference between the term reference position and centric relation? Centric relation is a point relationship of the lower jaw in the glenoid fossa. Typically, it's a manipulated position, and often we do things like leaf gauge by manual manipulation to find it. And usually our centric relation position is also our treatment position. Reference position is position of the mandible, which is non-manipulated. We use chin point guidance, which is a very light guidance. And we can use reference position as a starting point to find a treatment position, if necessary. To summarize, a reference position is diagnostically the baseline, or the zero position in the neutral zero method, like is used for other joints of the body in orthopedic studies. The definition of reference position is the unstrained retroborder position of the mandible from which movements start. Reference position is used for the analysis of all of our cases. Retrocontact position is the contact of a tooth or teeth along the retruded path of closure. It's the initial contact of a tooth or teeth during closure around the transverse horizontal axis, i.e. the first tooth to touch when the mandible is in reference position. Intercuspal position, or ICP, is the complete intercuspation of the opposing teeth independent of condylar position. Sometimes this is referred to as the best fit of the teeth regardless of condylar position. Synonym includes maximum intercuspation, or MIP. From this initial contact point, a slide from RCP to ICP must be assessed for effect on the temporomandibular joint. Now, many RCP to ICP slides are within 0.5 millimeters and are likely not that detrimental. But if they're more significant, at the level of the joint, they can create compression or distraction. And at the level of the teeth, they can create increased muscular involvement to close to ICP. It's also termed centric slide. Let's look at the difference between RCP and ICP in these photos. If the masticatory organ has to compensate for this large discrepancy between RCP and ICP every time the patient swallows, what do you think will happen? Next, we'll look at reference planes, the axis orbital coordinate system, Kondylography, hinge axis and RP, anatomic versus kinematic facebow, and the instrumental analysis instruments. Now, as you progress through the VieSID webinars and programs, we'll use reference planes to describe a variety of topics. The reference planes of the head include the horizontal. This is like sectioning the head superior to inferior. The frontal plane, which is like sectioning from front to back. And sagittally along the side. Now keep these photos in mind. We also define 3 axes in a system called the axis orbital, or the AO coordinate system. These are the X, Y, and Z axes. Once we're aware of these axes, we can define any point in space as a 3-point Cartesian coordinate system. The X-axis is front to back. The Z-axis is up and down. And finally, the Y-axis is left to right. A movement along the axis is defined by the term delta. For example, a delta Y change that is positive is a movement of the condyle to the patient's right by convention. A negative delta Y is a movement of the condyle to the left, i.e. in the sagittal direction. The axis systems can also be related to the movements of the hinge axis. This allows us to understand the movement in 3 dimensions. Without an ability to measure mandibular movement, we're limited in our abilities to understand the overall stomatognathic system. Now, this isn't a new idea. We've had recorders since the early 1800s. There are several things that make this type of recorder unique. We need the ability to measure mandibular movement at the condylar rotational axis, as close to the lateral poles as possible to minimize geometric distortion. The measurement of the lateral side-to-side or Bennett movement of the condyle is necessary. We have to have the ability to measure rotation in degrees about the hinge axis. By measuring in real time, we get a much greater comprehension of the dynamics, including the velocity of movement and the timing of disc displacement. And we can study occlusal dynamics and function, for example, in chewing, swallowing, and speaking. Kondylography fits all of these. The system has developed into a sophisticated electronic computerized recorder, which is backed by comprehensive, excellent research. MRI and cadaver data has been correlated with tracings in several studies to determine the sensitivity and specificity of the instrument in determining joint pathology through dynamic analysis. At the heart of Kondylography is an understanding of hinge axis, the definition being, hinge axis is a line that passes through the left and right mandibular condyles coinciding with the center of rotation of the mandible. Gentle retro-guided pressure allows us to limit movement to only rotation, and we can now find the rotational center of the mandible, which in this case occurs somewhere in the area of the condylar head. Once this rotational center is located, we can set our recording arms and allow our patient to relax and locate and fix the reference position for our further studies. This is an example of recording of mandibular movement as the patient opens. You can see in the right and left sides the tracings that are created. Understanding of the hinge axis allows us to do a true kinematic Facebook recording. This is critical to when our treatment will change vertical dimension, as it keeps the true rotational center. In the left diagram, you see the anatomic Facebook, which allows us to program our articulators. The mounting to the articulator is not quite accurate, and it's a little suspect in diagnostic evaluation, especially in verticalization. True kinematic hinge axis Facebook, however, allows us to accurately program our articulator, mount on the articulator accurately, and undergo our diagnostic evaluation, again, particularly in verticalization cases. Using our X, Y, Z axes, we can create tracings of how the hinge axis moves in three-dimensional space. We can view these on the right and left sides, also from the front, the side, and the top. Our X, Y, and Z coordinates relate also to the articulator. In this picture, the gamma reference SL articulator is shown. We can also transfer our mounted models from an articulator to a variator. This device has the ability to change the condylar position using dials to move the condyle in an X, Y, and Z direction. This might be used to define a new therapeutic position. The CPM is a device that works entirely extraorally using mounted models. The condylar movement in an X, Y, and Z direction from RP to ICP is revealed. While the magnitude of movement is exaggerated compared to the actual patient, it very nicely shows compression or distraction at the level of the joint. The same coordinate system based on the axis orbital plane allows us to overlay the kondylographic tracing to the ceph and assists us in assessing the dynamic analysis of the occlusal plane. This flexibility in the systems we teach at VieSID emphasizes that all of our patients are unique and require an individualized treatment plan and diagnosis based on the analysis of a wide variety of diagnostic findings. I want to thank you for joining this introductory webinar on nomenclature used in the VieSID programs. And on behalf of the Vienna School of Interdisciplinary Dentistry, I wish you all well as you pursue your studies.